Hi, and welcome to On Air with Vyaire, podcasts from the front lines, an educational podcast series featuring discussions with frontline medical experts about their experiences ranging from airway management or the dynamics of recognizing, preparing, and managing patients with COVID-19. At Vyaire, we are truly proud to partner with you on the front lines of the COVID-19 global health crisis, and thank you for the work you are doing to help improve outcomes for patients with COVID-19 around the world. The host of Podcasts from the Front Lines is Vyaire Vice President, Medical Director Michael Pedro, MD. This episode is focused on what high procalcitonin levels in COVID-19 patients means, and features our guest medical expert, Dr. Jessica Paulson, board-certified emergency medicine physician, assistant clinical professor, SUNY, Downstate Hospital in Brooklyn, New York. This podcast is for educational purposes only. The scientific exchange content in the podcasts from the front lines may address the off-label use of Vyaire devices and supplies that are the sole responsibility of the device or supplies owner, and is undertaken with the understanding that the owner assumes all liability for such use.
On today's episode, we'll discuss 5 labs to trends in patients hospitalized with COVID. We'll also discuss their importance and how to utilize them in clinical practice. We're lucky to have with us again Dr. Jessica Paulson, board-certified emergency medicine physician and assistant clinical professor at SUNY Downstate, a COVID-only hospital. Good morning.
Good morning. Thanks for having me again.
So last time you were on, you were discussing how at your hospital you were drawing 5 specific labs: procalcitonin, ferritin, CRP, LDH, and the 5th one, I believe, was
D-dimer.
D-dimer. So what were you looking for some of these labs? If you want to go over what some of the significance is, you can do them individually or just in general.
Yeah, well, I want to start by saying that first, I work in the emergency department, right? So the way we treat these really sick patients is pretty much the same. It doesn't matter what their labs show, right? So I do think the value of these labs are probably more for trending purposes and giving sort of signs of outcome potentials for improvement and stuff, right? I'll also say that no clinical decision should be made based on any lab value ever, probably. None of these labs
Sure.
are for COVID. None of them say for sure if you have this, you definitely have COVID, you definitely won't do well, you definitely will. And to take it all with a grain of salt and to think of them all as sort of pieces of a puzzle that you're using to put together your decision on how you manage these sort of very difficult to manage patients. But yeah, so we were getting these 5. That was at the behest of the virologists that asked us to, send these when we see them at the door. And they have sort of different values, I think. The first one that you mentioned is procalcitonin. Procalcitonin classically we use it in the pediatric literature to help us decide whether or not a patient requires antibiotics during an admission. It is fairly sensitive at differentiating a viral versus a bacterial illness. And I think their original thought was that it would be, and it's so when you have a bacterial illness, it's released in sort of mass, and then it's maintained in the blood by the cytokines that are released by the inflammatory response. And it is inhibited by a particular interferon that is low in a bacterial illness and high in a viral illness. But all of that aside, it turns out that there actually are a fair number of patients that have been proven not to have any bacterial illness by, I think, negative blood cultures and bronchial aspirates and stuff, who had low procalcitonin levels. So the idea is if your procalcitonin level is high, and that's a qualitative high, not quantitative, it doesn't matter how high, just if it's high, you should presume, like we usually do in the pediatric population, that there is a bacterial co-infection, and you should be looking for and or treating that bacterial infection.
Okay.
Again, that being said, if you present to the emergency department with multifocal pneumonia, even right now in the age of COVID, we'll test you for COVID, but we're giving you initial community-acquired pneumonia treatment. You're getting antibiotics at the door anyway, right? Even if your procalcitonin is low. That's not going to make me not give you antibiotics in case you have a co-infection or it's just bacterial pneumonia, right? We don't want to just assume it's and the idea of co-infections is just so common. It seems silly to withhold antibiotics, at least at first anyway. But procalcitonin can help us maybe differentiate the difference between a bacterial and just a viral only illness.
So in the face of COVID then, assuming your procalcitonin is high and you do test positive for COVID, then you're assuming you have a co-bacterial infection on top of a viral infection. Would that be correct?
I think that's correct, at least from what we know. We don't have a lot of studies yet, but I think it would be more interesting to find people who had low procalcitonin and were COVID positive and find out how many of those people actually exist. But for now, I think that if you have a high procalcitonin level, you have to continue to look for, like I would send blood cultures, urines, to continue to look for a bacterial co-infection if it's not a bacterial pneumonia co-infection.
Thank you for joining us today. To suggest a topic for future podcasts from the front lines or to stay informed, please visit us at Vyaire.com.